Dear Chairman, delegates, ladies and gentlemen, I'm very sorry I cannot attend this Eurofair 2019 because I got a flu a few days ago. Until now, I still have some fever and chilliness. For your safety, I decided not to come here, but I have to do my job. So I take this video to you and present my work. In this semi-live for low urinary tract dysfunction, I will present Botox, how I do it. The indications for Botox treatment in functional urology, including to treat incontinence, to treat voiding low urinary tract dysfunction, to treat storage low urinary tract dysfunction, and to treat BPH and chronic prostatitis, also to treat chronic pelvic pain syndrome. We can use a rigid cystoscope or flexible cystoscope to inject Botox solution into the bladder or urethral sphincter, or even we can use ureteroscope for pediatric injection of the urethral sphincter or detrusor. If possible, we use an injection cystoscope for suburothelial injection. That will be more accurate to deliver Botox into the site we desired. Regarding the anesthesia during intravesical Botox injection, either intravenous general anesthesia or intravesical local anesthesia is feasible. However, for patients who have a high level, more than T6 spinal cord lesions, we should avoid bladder overdistension during injection to prevent autonomic dysreflexia such as hypertension, bradycardia, or increased low limb reflex. And we should remember suburothelial injection is always more painful than detrusor injection. This is a Richard Wolf injection cystoscope, and we can also use the Olympus flexible cystoscope to inject Botox into the bladder or urethral sphincter. This is PPCS in Hualien. And the indication for detrusor Botox injection included neurogenic DO due to spinal cord injury, DSD with upper urinary tract deterioration, patients wish to become continent, and patients or his caregiver is able to catheterize. And idiopathic DO without large post-void residual. However, patients must understand the possible initial adverse events such as dysuria and urinary tract infection. And patients should be OAB dry or OAB wet refractory to medications. For urethral injection to treat neurogenic or non-neurogenic voiding dysfunction, Botox can be used to treat DSD in spinal cord injury or multiple sclerosis. We can deliver Botox into the transperineal to treat the DSD in spinal cord injury, or to treat patients with dysfunctional voiding due to idiopathic etiology or CVA, and the patients with poor relaxation of sphincter and low detrusor contractility. Even patients with detrusor reflexia and isolated sphincter obstruction can be treated with the Botox urethral injection. So for female patients, we inject Botox 100 units into 5 sites of the urethral sphincter. And during the injection, we can dissolve the 100 unit Botox into 5 cc and using the 1 milliliter syringe to inject Botox to the sphincter. The needle length of the 1 cc syringe is about 2 centimeters, so it will not inject into the bladder. For male urethral sphincter injection, using a cystoscopy injection is very easy because the male sphincter is about 1 inch in diameter and 1 inch in length. So we can inject the Botox laterally into the urethral sphincter, not too superficially, but to the urethral striatic muscle. For clinical application of voiding low urinary tract symptoms, we can treat patients with spinal cord injury, treat patients with multiple sclerosis, or detrusor underactivity who wishes to spontaneous voiding, and patients who have dysfunctional voiding due to CVA, idiopathic origin, or learned habit in pediatrics. Even in patients who have a large BPH, cannot urinate spontaneously, and are not feasible for surgical intervention, we can inject Botox into the prostate. Using a cystoscopy injection needle, we can inject the Botox into the prostate. However, it will cause very severe bleeding sometimes. So to avoid the prostate bleeding, we can inject Botox transperineally into the lateral lobe of the prostate. And using a transrectal ultrasound of the prostate, it is easy to insert the needle into the prostate bilaterally and then infuse the Botox solution into the prostate. Using one injection, we can deliver the Botox into one lobe and then switch to another lobe for the whole bladder infusion of Botox. So the clinical application for avoiding lower urinary tract dysfunction include the BPH Botox injection, and we can also inject Botox into the bladder neck if the patient has been proven to have bladder neck dysfunction. For neurogenic detrusor overactivity, detrusor Botox injection has been well established. Using 200 unit Botox, we can inject it at 20 or even 40 sites in the whole bladder wall. It is better to inject the Botox into the hypertrophied trabeculated bladder muscles to avoid injecting outside the bladder. And for storage lower urinary tract symptoms, not only spinal cord injury, but also patients with multiple sclerosis or patients with CVA or other intracranial lesions, and the overactive bladder can be treated with Botox injection. And pediatric meningocoel and the detrusor overactivity can also be treated with an appropriate dose. For overactive bladder, idiopathic overactive bladder, suburothelial Botox injection using 100 units is recommended. We injected Botox into about 20 sites of the bladder body or the bladder base. Using an injection cystoscopy, we can inject the Botox into suburothelial space without injecting outside the bladder walls to assure that all the Botox solution can be retained in the bladder. So for storage lower urinary tract symptoms, Botox injection can be used to treat OAB and IDO and the pediatric OAB. A patient with hypersensitive bladder, we call it OAB dry, can also be treated with Botox, maybe a smaller dose if the patient's overactive symptoms is refractory to conventional medications. For intravesical Botox injection, we can inject Botox into the bladder body or the bladder base. Or we can inject the Botox into the suburothelial space or into the detrusor muscles. We must remember that bladder wall is very thin. For a bladder infused about 150 to 200 milliliter, the bladder wall is only 1 millimeter in thickness. The bladder is distended and the bladder wall became thinner. So if you inject Botox into the bladder wall, please be sure to inject more superficially. Too deep injection will make the solution leak outside the bladder, and that will also lower the therapeutic effect of a Botox. So this slide shows the bladder wall thickness with the bladder volume. At about 200 cc, the bladder wall thickness is about 1 millimeter in that thickness. And at about 500 cc, the wall thickness is about 0.6 or 0.7 millimeter. So the bladder wall is very thin. Injecting into the trigone or bladder base can avoid chronic urinary retention and dysfunctional voiding or difficult urination after Botox treatment. Perhaps the injection may affect the movement of the bladder neck, and to avoid the bladder neck to reduce the bladder neck resistance during voiding. So trigonal Botox injection has been used widely to treat patients with flare edema, baseline large post-void residual, and the patients might have a lower maximum flow rate before injection. So when we inject the Botox into the trigone area, we inject 10 sites, including 5 sites along the interuretary ridge, and 5 sites at the trigone. But we don't inject the Botox into the bladder body, so that will maintain the detrusor contractility after the Botox injection and make patients easy to urinate. That is more useful for patients who have a large post-void residual at baseline. And we are afraid, because we are afraid patients might have acute urinary retention. In our previous study, no patients undergoing trigonal Botox injection develop urinary retention after Botox injection. However, the therapeutic duration seems a little bit less than patients who receive Botox bladder body injections. So another indication for Botox injection is the bladder inflammatory disease or lower urinary tract inflammatory disease, including interstitial cystitis, bladder pain syndrome, and chronic peri-pain syndrome, as well as chronic prostatitis, using 100 unit, 200 unit Botox injection into the bladder or the prostate or the proximal urethra or the urethral sphincter. Some patients have symptoms improve after Botox injection, and the multiple injections seems necessary to effectively reduce the painful symptoms. So in conclusion, we can use any instrument to deliver Botox solution to the urinary bladder, urethral sphincter, or prostate to obtain the desired therapeutic effect, to increase bladder capacity, reduce the urgency incontinence, or to relax the urethral sphincter, or to decrease the pain sensation in the pelvic floor or the prostate. And those sites and the depths are more important issues than injection technique. And more comparative studies should be done to obtain the optimal dose with high success rate and less advertisement events. Thank you for your attention. And here I would like to express my sincere apology again for not attending the Eurofair 2019. And please accept my apology and try to understand the flu that prohibited me to come here. Welcome you to Taiwan and Hualien again. Thank you.